In a biliary tract tumor, we know that currently, based on the ABC study, the FOLFOX is sort of considered a sort of a standard second-line therapy in patients who failed gemcitabine and cisplatin. So the TKI, such as Regorafenib, is a dirty TKI that really blocks multiple pathways, including VEGF, PDGFR, FGFR. And we know that some of the pathways is highly dysregulated in advanced biliary tract tumor. So we actually conducted a phase 2 study with the drug Regorafenib, which, as you know, is already approved in several other indications in advanced biliary tract tumor. It was a single-arm study. It was non-randomized, and it was non-selective. It was not enriched patient population. So we allowed all comers in patients who failed at least one line of therapy. Some could have failed 2 lines of therapy, and they received the Regorafenib single agent. And our primary endpoint was 6-month overall survival in this study. And based on the historical data, by giving Regorafenib in this setting, we did meet the endpoint of a 6-month OS. However, the response rate was very modest, at less than 10%. Okay, and the PFS was also modest, hovering around 3 to 4 months. So therefore, obviously, even though we met this endpoint, because this was a non-randomized study, that we definitely, based on this study, we know that this drug has some activity in this setting. However, obviously, more work needs to be done to see if this Regorafenib is better than the standard therapy, such as FOLFOX. And along with our study, there were actually 2 other studies that used Regorafenib in a similar setting. One was another phase 2 study by Dr. Sun et al., which was also published in Cancer as well, with about, 30 to 40 patients as well. In that study, the results was very similar to our study. However, there was a group in Europe that presented a randomized phase 2 study, small randomized phase 2 study with Regorafenib versus placebo in the patients who failed, who were refractory to standard treatment. And in that study, the primary endpoint was PFS. And actually, the study was positive. There was an improvement. The PFS doubled compared to placebo arm compared to Regorafenib. So once again, it's a very small study showing us that maybe the Regorafenib, a single agent, has some activity in this setting. However, I think the key point here is that we need to find out, once again, any kind of biomarkers that can potentially enrich the patients who may benefit from Regorafenib, because at this time we're giving this drug to all comers with, once again, with some toxicity that's associated with TKI, but with, once again, minimal to modest benefits. So I think moving forward, if you're going to use this kind of TKI, I think trying to find a biomarker that selects patients who may benefit from this drug may be beneficial.